Great. Hello. My name is Scott Weiner. I'm going to be discussing advanced concepts in opioid stewardship today. Thank you so much for attending this talk. I'm the director of the Opioid Stewardship Program at the Brigham and Women's Hospital in Boston. It's called Brigham Comprehensive Opioid Response and Education, or BCOR program. Also the director of our program in emergency medicine, health policy, and public health. I'm an associate professor of emergency medicine at Harvard Medical School. I have no financial conflicts of interest to disclose. The objectives today are going to be just high level, how you create opioid guidelines and how they can inform metrics, dashboards, and clinical decision support. I then want to take a deep dive into 3 separate advanced opioid stewardship concepts, including the scope of post-operative overprescribing of opioids and how to implement guidelines to address it. The second will be to identify challenges and opportunities for implementing a high-dose opioid tapering program, something which has been a big challenge for a lot of health systems. And the fourth is to describe an innovative model to address substance use disorder treatment at a hospital. Of course, if you're attending this course, you already know the statistics well, but it's just been devastating this past year in particular. And we've seen increases in overdose-related deaths for the past many years. And then we thought we hit a peak around 2018 or so. And then, of course, COVID hit, and we hit a record number of overdose-related deaths in 2020. About 93,000 lives lost. About 2/3 of those were from opioids, and we know that was about a 30% increase year to date by the most recent data from the CDC. Absolutely tragic. And we also know that a lot of us that work in hospitals and health systems really do feel a pressure to do something, to fix it, to address this issue. It comes from our patients that want our help. It comes from our clinicians that need guidance. It comes from the community who's looking to us. And not infrequently, it's coming from the government who imposes certain regulations for us that we need to follow regarding opioids and other substances. Now, hopefully you do have an opioid stewardship program in your hospital. I was actually just involved with another talk, and I learned that about 40% of hospitals actually have an opioid stewardship program. So if you don't have it yet, get on it. We actually put this paper in the Joint Commission Journal on Quality and Patient Safety in 2019, and it's really a cookbook to describe how you can pull together a team and make this happen. Please do look that up. We've also got a website, which is bcor.brighamandwomens.org, and we've really worked hard to just make as much as we can open access. We put a lot of guidelines and documents on there. Feel free to use whatever you'd like for your health system. I find that this is something where the more we share, the more we learn from each other, and that's really the spirit of this. There's kind of 3 main phases to what needs to be done from opioid stewardship, in my opinion. The first is creation of system-wide guidelines. And for us, we created 2 separate documents. One is for acute pain and one's for chronic pain. And what we did is we took guidelines such as the 2016 CDC guidelines for treatment of chronic non-cancer pain. We took what was required for our state laws, and we put them together and created documents and guidance that our clinicians can use. We found that it was helpful to do this because it really did set the expectations both for the providers and particularly for patients, because with patients that have pain issues, if you're withholding opioids for whatever reason, because you want to try and use non-opioid pain relief, which we know is evidence-based a lot of times, patients just don't want to feel like they're being treated differently. And so part of the guidelines are to standardize our treatment, standardize the care that we offer to our patients. It's also protective for the hospital. I'm hearing more and more cases where hospitals are named in suits from patients that had adverse outcomes after opioids. And this shows that the hospital is dedicated to using those medications responsibly. Once you have guidelines, the next step is to make metrics and reports and things that are actionable. For us, we created a whole opioid dashboard. It's got ambulatory care, emergency department care, and surgical care guidelines in there. For ambulatory care, we were able to look at the numbers of opiate prescriptions per 1,000 patient visits. That was helpful for us to address outlier practices within our system. In the ED, we look at things like the percentage of patients who are leaving with opiate prescriptions, the numbers of pills per prescription. And we've been able not necessarily to reduce these numbers, but to really tighten the mean. So we don't have such outliers, just the practice is a lot more consistent now. And finally, surgical, I'm going to talk about at length a little bit later in this talk. Once you have metrics and reports, then you can create clinical decision tools. These are just a couple of examples that we have. One of them warns you if you've reached more than 90 morphine milligram equivalents per day. Another one reminds you if you don't have an opioid treatment agreement on file for patients that are on chronic opioids. We have other ones that remind about naloxone co-prescribing for patients on high dose or chronic opioids. We have one that I really like, which is when a patient is discharged after a cesarean section or vaginal delivery. If they receive an opioid, when they come back to clinic, it reminds the provider to ask them if they've finished using that medication and to discard it if it's no longer needed, which it frequently isn't after delivery. And then finally, we have one in the upper right corner, which is puts all of it together. It checks to make sure that the provider has looked at the prescription drug monitoring program, checks to make sure that there's an opioid agreement on file, make sure that there's not opioids and benzodiazepines together, and really is just a holistic view that's used whenever a provider is refilling a prescription for opioids. So those are just the basics. And now again, I want to dive into 3 specific advanced concepts. The first one is post-surgical opiate prescriptions. This is probably the most common post-operative complication. And I know it's a little bit unusual to hear that because we think of things like infection or readmission is the most common. But if you look at this, about 7% of patients who weren't on opioids before their surgery will be on long-term opioids after their surgery. That's life-altering. That means that they're going to be on these medications for a long time. And so even though we want to, well, at the same time, we want to treat pain compassionately, and often that involves the use of opioids, we also don't want to be stuck in a situation where the patient is then dependent on them and uses it far beyond when their pain is expected to subside. In fact, there was this meta-analysis from 33 studies that did find that 7% of patients continued to fill opioids more than 3 months after surgery. And the second one was actually pretty stunning. An analysis of 6 studies found that between 67 to 92% of post-surgical patients had opioids that were unused after their surgery. So they took some of the pills, but they didn't finish them. And then we found that 42 to 71% were entirely unused. The patient didn't even use the prescription at all. Yet about 15 to 29%, depending on the study, reported opioid-induced adverse effects. This just makes the case that we need to right-size how we use opioids after surgery. At our hospital, we've released guidelines. This is the guidelines for after general surgery. And I think you'll find it's pretty interesting. After you get your appendix out, the most we give is 10 pills. Same with gallbladder. For the bigger surgeries like colectomy, we give up to 20 pills. This is a big change from what we were doing years ago, where we were giving 30, 60, or 90 pills after discharge. But what we found is that patients do really well with this. They often don't need more than that. And what happens is that after the acute pain subsides, they're fine using non-opioid pain medications. They don't have them sitting around in the medicine cabinet where they can be diverted, or they don't use them excessively to the point where they develop tolerance and then withdrawal if they stop using them. If you're going to embark in this journey, I want to share 2 different resources with you. The first is a great program out of Michigan called OPEN, and you can just Google Michigan OPEN Project. This is a very rigorous evidence-based approach in which they looked at all sorts of surgical procedures. They looked at the prescriptions that patients got. They interviewed the patients before and after their surgeries and their use of opioids, and they found that patients often didn't need the large numbers that were being prescribed. This group publishes their guidelines, their recommendations, and they update it every year as well. So this is a really good place for you to start evidence-based. And then the final part to this is about education. Patients need to be informed that they're going to have pain after surgery. Our job is to make it bearable and manageable and that it will improve, but not that it's going to take it away completely. It's unrealistic to think that you will have, again, your gallbladder out, open colectomy, and that you're going to have 0 pain. So managing and tempering expectations is important in a way that patients can be comfortable, even with non-opioid medications, but they might not have 0 pain until they heal. We've created our own post-surgical guidelines. There's also a very good set of guidelines at the American College of Surgeons, and you can see that on the page here, and you can freely download this. It's a fantastic resource, and you could just plug this into your instructions tomorrow and get started. Shifting gears, we're going to talk about tapering of high-dose opioid prescriptions. This has been a controversial topic, and it needs to be done very thoughtfully. You've all heard about the challenges of opioids and what the cause of the opioid epidemic, the quote-unquote epidemic, has been. And we know that early on in the epidemic, it was often attributed to prescribed pain medications. The pain is the fifth vital sign, etc. We increased our prescriptions for opioids, which I'll show you on the next slide. But I thought this chart really captures this nicely. The yellow are deaths attributed to prescribed opioids. The orange are deaths attributed to heroin. And the red is deaths attributed to synthetic opioids like fentanyl. And the really interesting thing here is that you can see that although we've put more attention for several years on heroin, and then particularly these past 4 to 5 years on synthetic opioids as being the lion's share of reasons for having overdose, you can see that yellow, the amount of yellow, really hasn't budged. So although we are seeing increased deaths from heroin and fentanyl, the numbers of deaths from prescribed opioids is staying the same. And it essentially means that we can't lose sight and can't lose track of the prescribed opioids. I thought this was a fascinating chart. This looks up through 2020, through last year. This is the prescribed, or actually the dispensed, opioids in the United States from 1992 to 2020. And it basically converted all the opioids to morphine milligram equivalents. There's conversion factors where you can convert any opioid to an equivalent of morphine. You can see back in 1992, we prescribed about 25 billion morphine milligram equivalents in this country, which is quite a lot actually. But in 2011, we were at 10 times that rate, 250 billion morphine milligram equivalents. Since that, we've had increased recognition of the overprescribing of these medications, and there's been a marked decrease. And you can see that the pendulum has swung back tremendously. We're now to the level that we were at around 2001 or so. So it's going to be interesting to see where we settle out from this. And my hope is that we don't overshoot it, because I think it was clear that we were undertreating pain in the 90s, and then we overtreated it in the early 2000s. We'll see where we settle. But if you actually look at the prescriptions for different doses, you can see something interesting. The first is that the total, and this is from 2011 to 2019, decreased by about 50%. But the majority, the largest number of prescriptions that decreased were for those of greater than 90 morphine milligram equivalents per day. They decreased by about 70%. And probably the reason for this are the CDC guidelines in particular. The CDC guidelines in 2016 came out, said for non-cancer chronic pain, you should avoid prescriptions over 90 MME per day unless there's careful consideration and justification. At our hospital, what that meant was that we actually had a mandate from our hospital board of directors to avoid high-dose prescriptions. And when this happened, they came to me as the director of the Opioid Stewardship Program and said, fix this. Meanwhile, I know that we have legacy patients. We have patients that were on high-dose opioids well before the 2016 guidelines. So we had to figure out what to do. First thing is we looked backwards. We looked at from 2018 to 19, we had about 77,000 pill form opioid prescriptions written, and about 15.7% were for more than 90 morphine milligram equivalents per day. And just that was very eye-opening for us. We didn't realize that we had so many that were for high dose, and I would encourage you all to do the same at your systems. But then when we drilled down deeper, we found that just 2 clinics were responsible for nearly half of all of that prescribing. And so we instantly knew where our target was. And again, this is an example of looking at the data and how that can help you. So what we did is for those 2 clinics, we rolled out a comprehensive program. First of all, starting in July 2019, our trainees and fellows were prohibited from writing opioid prescriptions for more than 90 morphine milligram equivalents per day. This basically did 2 things. The first is it did make it slightly more inconvenient for the attending doctors, who then had to write the prescription and had to think about it. But it also set the stage for our trainees that it's no longer okay to write these prescriptions. And I know this is controversial because there are a lot of patients that have chronic non-cancer pain that are on these medications, and they need these medications to survive and to function. But we have found that if you do this in a compassionate way, the majority of those patients can be tapered to safer levels. And hopefully it should go without saying that we know that the risk of overdose death being on more than 90 to 100 morphine milligram equivalents a day is about 10 times higher than those who are on much lower doses, under 40 morphine milligram equivalents per day. So it is a safety issue for the patient. It is a best practice. So in addition to preventing prescriptions for opioids at high doses for our trainees, We also promulgated system-wide best practices as part of those guidelines I mentioned before, a prescription drug monitoring program check prior to every prescription, naloxone co-prescriptions for those on chronic opioids, pain treatment agreement for everyone on chronic opioids, random toxicology screening at least once a year, clinic visit every 3 months. We rolled out safe tapering recommendations. We avoided opioids with benzos and made sure that they were not prescribed in combination. And then we performed random chart reviews every month to make sure that the providers were following these guidelines. We then shared the prescribing practices with their peers so we could normalize and tell people where they're at, similar to what I mentioned from the previous metric tools. We have a dedicated pharmacist who is there to help safely taper patients. She's wonderful, she's passionate about this, and she actually has prescriptive authority, so she can write prescriptions and really takes out the middleman, essentially, because she can say, we're going to be very evidence-based and very algorithmic about your taper, and again, not make patients feel like they're being singled out. We offered psychosocial support for patients with difficulty with the tapers, rapid access to psychiatry, rapid access to our substance use disorder bridge clinic, which I'll talk about at the end of this talk. And we had monthly meetings with our chief medical officer, compliance, and other leaders. And we're really pleased with the results. On this chart, you can see the blue columns are prescriptions for less than 90 morphine milligram equivalents per day, and the red columns are those for 90 morphine milligram equivalents per day. And from when we started doing the taper, you can see a marked decrease in the number of the high dose opioids, and not much of a change of the lower dose opioids, which we're happy with, we're fine with. One thing to note though is that after the intervention, this is about 18 months of data. This is not something that's going to happen overnight. This is actually something that takes place over months. Frequently, you're going to taper around 10% of the dose per month. And that can be a long taper if a patient is already on very high doses of opioids. So for us, we did find that this multifaceted, multidisciplinary model could safely reduce the numbers of high-dose opioid prescriptions, and it can take months. It's also not appropriate for all patients, but we try and justify when it's not appropriate, and we try and make that a small number of patients. We want to find out what happened to some of the patients that dropped out, that no longer were followed at the clinic. We don't know if there were unintentional overdoses, but our preliminary analysis shows that there were not. The provider experience too, because I think this was a big change for a lot of the providers. We also started to look at the patient experience, and we actually looked back at our patient, the surveys that are sent out to patients after their visits, and unfortunately, the vast majority of them are satisfied. Because we found that with this approach, patients do understand it. They do see the news as well. They do see that high-dose opioids are dangerous. They're also motivated. And actually, frequently, we do see functional improvements in pain for our patients after they're off of the high doses. Just a small warning, though. This paper came out just a couple months ago and showed that looking at a large commercial insurance data set, for patients that did have tapers, they saw increases in the numbers of overdoses and mental health crises associated with those decreases in doses. Now, this paper was unable to look at what else was offered, such as the psychosocial support that I mentioned before, but I just want to highlight that these are unintentional consequences that can be, the patients can have if you do embark on a program like this. It needs to be done very thoughtfully, and you need to embrace the patient and make sure they have all the services they need, including for patients that have exacerbations of depression when they stop their opioids, or those that truly do have opioid use disorder that need addiction treatment in addition to their pain treatment. And that brings us to the third advanced concept, which is substance use disorder treatment. At our hospital, I'm really proud of the model that we implemented, which was after a couple of other models that happened throughout the country. Most notably, there was landmark work from Yale University, which showed that if you were able to start a patient who presented to the emergency department with withdrawal or seeking help for their opioids on medication for opioid use disorder, such as Suboxone or buprenorphine, and get them into a clinic within the next 24 to 72 hours, next business day, and have them follow up, you more than double their chances of being in active treatment at 1 month. The numbers went from around 30% to more than 70%. There's very little things in medicine which are so much effective as this. And so we've adopted that same model. We have a bridge clinic. It basically will take patients on a walk-in basis and an on-demand basis. We prefer that they do have an appointment. We'll also do telehealth, especially in the age of COVID. But you know what? If a patient is still actively using drugs, that's okay. We just want to be able to engage with them. We want to be able to share harm reduction resources with them. We want to be able to help them. And when they're ready for recovery, we're there for them. And this model works because we know that if you take a patient in withdrawal and you tell them make an appointment 2 weeks from Thursday, it's not going to happen because the drugs have hijacked their brain and they're not able to do that. So patients do need a bridge. Our bridge clinic has addiction psychiatrists, internal medicine physicians. There's an ID doctor on staff that handles infectious disease complications. There are case managers, care transition specialists that help with long-term placement. And it's just been a very successful model that I would encourage all of you to pursue. We've also, another part of this was getting prescribers to have their waiver to prescribe buprenorphine. As many of you know that there previously was an 8-hour training course that was required for physicians that were prescribing buprenorphine to their patients, and a 24-hour course for advanced practice practitioners such as nurse practitioners and physician assistants. Fortunately, this past March, those training requirements went away. You still have to apply for the waiver, but at least you don't have to do long training. And that's to prescribe up to 30 patients at a time. So this works for the vast majority of our providers, whether they be in the emergency department or in the hospital. And that was very helpful for us to be able to get people waivered and also educate them at the same time. And really the innovative part of this that I'm really proud of that I didn't see coming, but has really been transformational, is the idea that we can get people started on medication for opioid use disorder treatment, again, buprenorphine most commonly, while they're in the hospital for medical complications of injection drug use. And we can send them home with a PICC line or a long-term indwelling catheter. So the prototypical patient would be someone who had injected drugs, they had a bloodstream infection, goes to their heart, and they get endocarditis. They typically need to be on about 6 weeks of IV antibiotics. Unfortunately, the oral antibiotics just don't work as well, and IV is better. Previously, no one felt comfortable sending those patients home with a PICC line in place because there was fear that they would then inject through their PICC line. What we found is that if we can engage patients while they're in the hospital, get them started on treatment, have them see a recovery coach, then have them follow up in the bridge clinic at least twice a week afterwards, they can safely go home with a PICC line. It's not for everybody. We have to make sure that they have stable housing, there's not active drug use in the house, that they've got transportation to come back to the clinic, that they're stable on the medication before they leave the hospital. But our patients are very honest with us, and they tell us, we're not stupid. I know that I might have an addiction to drugs, but I'm not going to inject drugs into this line that I know is going directly into my heart. Others have told us, if I need to access a vein to inject drugs, I know how to do that. I don't need the PICC line to do that. So it's been a change. It's been uncomfortable for a lot of us, but we found through studies like this one, which you can look up or you can reach out to me for a copy of, that patients actually do well with it. Again, not for everybody, and it's not perfect. We had 15% of patients relapse with our initial cohort. Relapse is a part of recovery, and it's expected. So that's not failure. That just means that we know that a certain percentage will relapse, and we're there to help them when we can and when they do relapse. The biggest sell for you, for your hospital, your health system, is days in the hospital. Because previously we had lots of difficulty being able to transition these patients to a rehab facility because many of them wouldn't take patients with active substance use disorder. And so our patients would end up going to the 2 rehab facilities that would take patients, and we were told repetitively that drug use there was rampant. So it was actually much worse for them to go to these rehab facilities. It's safer for them to go home. Another project we're working on is for a pathway for patients that are admitted with cardiac surgery. You might have heard this as well in the news of patients that have cardiac surgery because their valve became infected and no longer works. They have an open heart surgery to fix their valve, and then they relapse, use again, and then they need a repeat surgery. Or when they're in the hospital, we're so focused on repairing their valve that we don't treat the underlying issue. We don't treat the substance use disorder, which is very unusual for me because, like, if you have diabetes and you might have a diabetic foot infection, we don't just treat the infection and not treat the underlying diabetes. Same thing with substance use disorders. So if we rolled out a pathway in which we have our nurses have a consistent message, we have communication with the team so there's not splitting of different providers, or there's not patients who are told different things by different providers. We've actually rolled this training out in our simulation center, and we've enacted cases with our teams. It's been really successful. And the last two things I want to just mention are first about National Recovery Month, and the final one is about stigma. National Recovery Month happens every September. And for us, this is the time when we reboot our initiatives. We have the majority of our information booths, our tables. You can see there a picture on the top with two of our recovery coaches. We have trainings, like you can see on the bottom, we're doing a Narcan training session for people in the hospital that were walking by a highly trafficked area. We have an exhibit, photojournalistic exhibit about recovery. And then finally, the one on the right was a very moving exhibit we had this year. We planted purple flags, one for every life lost in our state in 2020. We put it right on the main lawn in front of the original part of our hospital. Things like this are a good moment to spotlight recovery, and I would encourage you to embrace this. There's a lot of materials available online that you can use for your own efforts, and it again is a way to really highlight this disease and that it is treatable, that recovery is possible. And the final part I want to mention is just about stigma. Unlike most any other disease, the stigma with this one is very burdensome. And we know that it's very detrimental to care for patients who are seeking help. And unlike other diseases, where if you say someone is diabetic, it's not that big of a deal. If you tell someone, a medical professional, telling a patient that they're an addict, it's very hurtful to them. It's putting a stigmatizing language on that patient. And we see that with other language as well, such as if you have a toxicology screen that comes back positive and you call it dirty, that implies that the patient is dirty. Same thing if you say someone is clean, then what's the opposite of clean is dirty. So we really do think that words matter. There is a language that's used for patients that are in recovery. They might go to a Narcotics Anonymous meeting and say that they are an addict or they're an alcoholic, and that's okay. If they want to identify like that with those words as part of their recovery, we should support that. But as medical professionals, we need to be more careful. And so we rolled out a Hospital Without Stigma pledge. You can see the terms there. We're happy to share this as well. It's also available on our website. We just remind staff that the words do matter with this disease. And with that, I'll conclude. I'm happy to answer any questions you might have by email. That's my email address there. Please go to our websites. We have two. One is bcorp.brighamwomens.org, which has a lot of these guidelines. poppy.bwh.harvard.edu is our program in opioid and pain innovation. You can learn about some of the work that we're doing there. And then I also provided QR codes, which will get you directly to our opioid prescribing guidelines and our opioid tapering guidelines. I hope this was a helpful talk for you. I hope you enjoy the rest of the conference, and thank you so much for your attention.